But did you know that you can actually take thyroid medication in the afternoon? Yeah, I didn't either. You know that viral trend, I was this many years when I found out XYZ? Yeah, that was me, 34-year-old practitioner, practiced about 8 to 10 years at that point. And I had no idea that thyroid medication in the afternoon could actually have advantageous benefit to me and to my patients. So why would I do that? What's the point of it? And which thyroid medications can you use in that way? Well, largely, here's the difference, or here's the stickiness of it. So levothyroxine or Synthroid is synthetic hormone, contains T4. Well, what's T4? T4 is what's produced from your thyroid gland in a large quantity. The average 150-pound male, female makes about 90 micrograms of it first thing over a 24-hour period in the morning. You make another 5 micrograms of something called T3. Now, T4 converts into T3 throughout the day upon demand. T4 is inactive, T3 is what gives you the benefits of thyroid capacity. So thyroid functions, for example, strong hair, skin, and nails, good digestive system, cardiac function, feeling the right body temperature, more in the 98.6 degrees versus the 97s, brain fog gone, mental clarity, no muscle aches, joint pains, dry skin, things of that nature. The things you think of with a sluggish thyroid. So going back to T4, T3, average human being makes 90 micrograms of T4 in the morning with 5 micrograms of T3. So you get a lot of extended release form that your body theoretically assumes and presumes with no genetic deficiencies, no toxic environmental pollutants, and with a functioning organ system that you can convert that T4 into T3 by your peripheral tissues. So when you exercise, all of a sudden, skeletal muscle, we need more energy. So we're gonna take some of that T4, we're gonna convert it into T3, and about throughout the day, you convert 25 micrograms total of T3. So when somebody comes into the office and they said, hey, I had a thyroidectomy, worst case scenario, right, as to what thyroid disorders can go wrong, I need replacement hormone. Well, the standard of care is to put them on something called levothyroxine or Synthroid. It is T4 only in its product form. Well, why is that important to know? Because they don't have a thyroid anymore. So if they're going to take T4, we're going to hope, cross our fingers, and presume that that T4 will convert into T3. But side note, sometimes it doesn't. And so people can take all the T4 in the world, but they don't actually have the functional component, what I call the short-acting T3. So it's a very interesting conversation because not one size fits all when it comes to thyroid hormone therapy. And we're talking about traditional hypothyroidism. So this means on lab reference ranges, for example, your TSH will be greater than 10. Your T4 might be lower than 1.0, 1.1. That's about where you want your low normal to be. And then your free T3, most providers do not check today anymore. However, in functional medicine world, or in, let's say, bioidentical hormone therapy replacement land, we know that a free T3 of somewhere between 3 and 5 is ideal. So you have a hypothyroid patient because the thyroid was taken out and gone away. I get them on T4, Synthroid, levothyroxine, and I'm like, great, did my job. But they're miserable still. And they come in and they're like, I just feel sluggish. I can't lose weight. My hair's falling out. Help me, please. And you feel bad. And you're like, but I did everything right. I mean, I gave you the right dose. Your labs look great. What do you do next? So this is where the case for T3 comes in. And it's interesting to me because I was, again, how many years old? 34 years old before I knew that, one, you could use hormone therapy, thyroid replacement in the afternoon, but then also did not know that what I was giving people might not actually be the full solution. I actually didn't even know at that point that there was something called Cytomel or liothyronine, which is synthetic T3. So levothyroxine and Synthroid are synthetic, as is Cytomel and liothyronine. You have synthetic T4, you have synthetic T3. You can use a combination to give people both the long-acting form, the T4, and then the short-acting T3. For reference point, T4 lives in the body for about 2 weeks. That's a long time. T3, however, has a peak half-life, usually meaning half of it's gone by the time you've digested it in 6 to 8 hours. Sometimes people say about 20. But that's a lot shorter than 2 weeks. So where this becomes relevant and important is going back to this hypothyroid patient who doesn't have a thyroid, has T4, you've given them the drugs, but they're still having symptoms because maybe they're not able to convert that T4 into T3. Introduce synthetics like leothyronine, Cytomel, which is that instantaneous T3,